To understand pleural disease, we must look past the major organs and zoom in on a membrane barely a fraction of a millimeter thick. In its healthy state, the visceral pleura wrapping the lung and the parietal pleura lining the chest wall sit flush. They are lubricated by roughly 10 milliliters of physiologic fluid, making them indistinguishable on most scans. We establish a baseline comparing normal pleural anatomy across imaging modalities. In this contrast-enhanced CT, the combined pleural layers appear as a single thin line pressed against the chest wall. The ultrasound image identifies the border as a distinct hyperechoic line. The pleura as a potential space, becoming clinically visible only when it is forced open by one of three physical states: air, fluid, or abnormal tissue. Mastering the diagnosis requires matching the physical properties of the disease to the specific acoustic, radiologic, or metabolic strengths of ultrasound, CT, MRI, and PET. Expansion by air, a pneumothorax, breaks the vacuum of the pleural space. This radiograph shows the visceral pleural line physically pulling away from the chest wall. Cross-sectional CT imaging reveals the structural complexity of that air pocket, identifying where the pneumothorax is loculated by pleural adhesions. While CT provides structural context, point-of-care ultrasound serves as a rapid detection tool, confirming free air by detecting the loss of normal lung sliding. To understand the diagnosis, we look at a normal lung using M-mode ultrasound, which plots tissue motion over time. Normal respiratory motion creates the seashore sign. The static chest wall forms parallel lines at the top, while the granular artifact below represents the moving lung. The acoustic profile changes completely when air occupies the pleural space. The air blocks the ultrasound waves, eliminating the granular motion artifact. This leaves only the static, parallel lines of the barcode or stratosphere sign. Once the physical state of air is confirmed, CT imaging becomes necessary to evaluate the underlying causes in the lung parenchyma. For instance, a catamenial pneumothorax in thoracic endometriosis requires CT to map structural damage caused by endometrial tissue bleeding into the thoracic cavity. In air-based states, ultrasound provides the dynamic confirmation, while CT identifies the underlying anatomical cause. When fluid expands the space, we must distinguish between low-protein transudates and high-protein exudates driven by inflammation or malignancy. We use Light's criteria for classification. An effusion is an exudate if the pleural to serum protein ratio exceeds 0.5, or the lactate dehydrogenase ratio exceeds 0.6. Hounsfield units, the standard quantitative scale for radiodensity on CT, often provide identical readings for both transudates and exudates. This axial CT demonstrates the challenge. The fluid shows very low attenuation, which usually suggests a transudate, yet this is actually an exudative chylothorax. The high cholesterol content of the chyle artificially lowers the density on the scan. CT is highly effective at identifying morphological markers of inflammation, like the split pleura sign in this empyema. Severe infection causes hypervascularity. Under contrast, the visceral and parietal layers enhance, becoming clearly visible as they are physically pushed apart by the encapsulated exudative fluid. While contrast CT maps the inflammatory envelope, it often misses the internal mechanical organization of the fluid. Ultrasound reveals the internal structure of the infection. These thick, echogenic septations divide the fluid into compartments, which directly informs the drainage strategy. For fluid states, contrast CT identifies the inflammatory boundaries, while ultrasound reveals the internal septations that guide clinical intervention. The most difficult diagnostic task is expansion by tissue, where we must differentiate stable environmental fibrosis from active malignancy. Benign pleural plaques from asbestos exposure present a specific radiographic signature. These dense calcifications create the irregular holly leaf sign. CT confirms their distribution. The plaques exhibit abrupt shoulders, strictly following the parietal pleura along the ribs and diaphragmatic dome, while notably sparing the apices. This predictable morphological footprint allows us to separate historical environmental scars from the chaotic growth of a tumor. Recognizing the holly leaf pattern and its parietal distribution prevents misdiagnosing an old environmental exposure as an active oncologic threat. Malignant pleural mesothelioma is an aggressive cancer. Its hallmark CT signature is a rind-like encasement. irregular pleural thickening exceeding 10 millimeters invading the chest wall. PET reveals metabolic activity. A high SUV max indicates intense glucose metabolism, helping differentiate highly active sarcomatoid subtypes from epithelioid ones. Aside from mesothelioma, the pleura can produce massive, localized mesenchymal tumors called solitary fibrous tumors of the pleura. When these tumors grow large, we use MRI to characterize their internal soft tissue architecture. T2-weighted MRI maps the tissue matrix with high precision. Areas of low signal represent dense fibrous tissue, while bright, high-intensity regions pinpoint cystic degeneration, myxoid change, or necrosis. When tissue expands the pleura, contrast CT defines the boundaries, but PET and MRI quantify the metabolic activity and internal tissue composition of the tumor. Pleural pathologies are diverse, and no single modality can solve every diagnostic challenge. For air, ultrasound provides instant confirmation via the barcode sign. For fluid, contrast CT exposes the inflammatory split pleura sign, while ultrasound identifies the internal septations. For tissue, benign plaques are marked by abrupt calcifications, while malignancies require the metabolic and structural detail of PET and MRI. Diagnostic precision relies on matching the specific physics of each imaging modality to the physical state of the underlying disease.